Empezamos con la primera ponencia, Ciencia y Práctica Clínica, que va a moderar la doctora Claudia Valenzuela del Hospital de la Princesa. Tendremos una primera sesión técnica, que es patogenia y diagnóstico del Aelam, de las guías académicas a la práctica clínica, que el ponente que la llevará a cabo será Sergio Harari, del Ospedale San Giuseppe de Milán, que por problemas sobrevenidos con su vuelo estará en streaming. Y la segunda ponencia, sesión técnica, será presente y futuro del manejo farmacológico del Aelam. El ponente será el doctor Vincent Cottin, de la Universidad de Claude de Lyon, de Francia. Y después haremos un coloquio, sesión de preguntas y respuestas. Adelante, doctora.
Muchas gracias a todos por estar aquí esta mañana y la verdad que es un placer, como siempre, acompañaros. Aprovecho la ocasión pues para presentar a dos compañeros que sé que tenéis mucho interés en escuchar y además en hacer muchas preguntas. El profesor Sergio Harari de Milán, especialista en enfermedades raras, en hipertensión pulmonar, enfermedad intersticial, será el primero que comience con la ponencia. Sergio, no sé si nos estás escuchando, cuando quieras puedes empezar y luego al final de las dos ponencias serán las preguntas.
Thank you very much, Claudia. Thank you very much for the invitation. I am really sorry that to not be in presence. Unfortunately, I missed my flight yesterday, and I really apologize for not being with you today. So I will discuss with you in the next few minutes the pathogenesis and diagnosis of LAM, focusing on how we can move from academic guidelines to everyday clinical practice. So we know that RAM is a rare multisystem low-grade progressive systemic neoplasm characterized by the proliferation and tissue invasion of abnormal smooth muscle-like cell occurring in a sporadic form almost exclusively in women or associated with tuberous sclerosis, and is characterized by the abnormal proliferation of these very particular LAM cells, the formation of lung cysts, the presence of renal angiomyolipomas and lymphangiomyomas. And over the last decades, we have made substantial progress in the understanding of the pathogenesis of this disease. The initiating event is usually a mutation in TSC1 or 2, most frequently TSC2, leading to dysfunction of amertin and tuberin, and as a consequence, hyperactivation of the mTOR pathway. This results in increased cell motility and evasiveness, protein translation, promotion of angiogenesis and lymphangiogenosis, and abnormal cell differentiation and proliferation, all contributing to tumorigenesis. Based on this mechanism, mTOR inhibitors have become central in the treatment of LAM. The mouse trials in 2011 showed that sirolimus, an mTOR inhibitor, can stabilize lung function in patients with this disease as long as the drug is administered, and it is currently the only approved drug worldwide. In our own experience, sirolimus has significantly, in real life, changed the natural history of the disease. Here we compare the mortality before and after the introduction of sirolimus on 162 patients followed over years in our center, and after 2011, the widespread use of sirolimus translated into a significant improvement in survival, clearly demonstrating that this treatment can modify the story of the disease. However, not all that glitters is gold. This is a cohort of 74 patients that we followed for at least 5 years. And as you can see, initially we observed a honeymoon period with stabilization of pulmonary function. And after some years, a significant decline in FEV1 became evident in some patients. One of the mechanisms that may contribute to the loss of efficacy of sirolimus is related to autophagy, which remain an important area of ongoing research. PSC2 mTOR2 is an alternative non-canonical pathway that is not controlled by sirolimus, but can activate over time and be responsible of the progression of the disease. So another area of research is how to work with therapeutic approaches in this non-canonical pathway. Clinically, many patients present with recurrent of bilateral pneumothorax and abnormal lung function test together with a typical radiological feature of lung. Both the ERS and 2012 and ITS, Japanese Respiratory Society 2017 guidelines agree that a typical high-resolution CT scan with diffuse round thin wall cyst plus at least one of characteristic feature such as tuberous sclerosis complex, chylous effusion, angiomyolipoma, or lymphatic involvement allow a confident diagnosis of lung without the need for lung biopsy in some cases. And serum VEGF-D has emerged as an important diagnostic biomarker. A threshold of 800 provides a specificity sensitivity around 70% and high specificity reported in the literature. In our experience, the sensitivity is however a little bit lower, around 54%. And of course, we know that higher VEGF levels are associated with more extensive lymphatic involvement, such as chylous effusion and lymphangioliomyomas. Again, coming back to our experience in 162 patients evaluated since a long time to November 2017, we had 61 that had a histological diagnosis, and if we consider those with clinical radiological diagnosis, 101, 74 had a definite diagnosis according to the ERS guideline, and if we consider also a VEGF-D level greater than 800, we have 10 more patients that have a definite diagnosis of LAM. So, despite clinical guideline, the diagnosis of LAM is not always straightforward in real-world practice. And I will show you two illustrative clinical cases where the clinical interpretation was challenging and the final diagnosis required a careful integration of imaging, biomarker, and in one case, histology. The first case is a 40-year-old woman who had been diagnosed with Lyme in another center. Her history included a family history of renal cancer, a patent foramen ovale. She underwent a CT scan after a car accident, which showed cystic changes interpreted as Lyme. As you can see, there are several cysts in the lung, bilateral, further investigation, always in the other hospital, show a normal abdominal MRI, a VGDF level low, and normal pulmonary function test, except for a mild reduction in the LCO. Despite this, she was labeled as having Lyme. In our Lyme clinic, a more detailed review of the imaging and clinical picture led us to reconsider this diagnosis. And as you can see, if we look careful to the skin of this patient, some lesions are present, and these are angiofibroma. And the final diagnosis was of Bigot-Dubé. The second case is a 39-year-old woman, an ex-mild smoker, who had undergone 2 cycles of ovarian stimulation for medically assisted reproduction, with 1 miscarriage and 1 full-term pregnancy. During the labor, she developed pneumothorax, which raised the suspicion of an underlying diffuse cystic lung disease. As you can see, she has the chest drainage. However, her CT pattern was not typical for Lyme, and the diagnosis remained uncertain. Finally, a surgical lung biopsy was performed. Histology showed a pulmonary parenchyma with focal proliferation of planned spindle cells delimiting cystic formation, with a combined smooth muscle phenotypes and melanocytic feature compatible with a sarcoma family lesion consistent with pulmonary Lyme. The neoplastic cells were positive for HNB45, smooth muscle actin, desmin, and estrogen and progesterone receptors, and negative for CD20, melan A, S100, and other marker. Her VGDF level was 738, below the classic 800 threshold, showing that Lyme can be present even with the VGDF level are in the green zone. But so if we stay according to the guidelines, we do not have a diagnosis of Lyme because we need a characteristic or compatible lung high resolution CT, and at this time the patient did not have a compatible high resolution CT. The VGFD was normal. We had only histology. However, after 1 year, the CT became really very suggestive for Lyme. So Obtaining a definite diagnosis of Lyme is crucial and is not always easy. It has an important impact on quality of life, on lifestyle choice, and major decisions such as pregnancy. Moreover, we do have now a specific treatment, sirolimus, and not all cystic line disease share the same prognosis and therapeutic option. Therefore, distinguishing Lyme from other diffuse cystic line disease is essential. How we can improve the diagnosis? We can improve the diagnostic accuracy with better imaging tools and better biomarker. Artificial intelligence is now emerging as a promising help in the interpretation of CT scan. For example, convolutional neural network models have been trained on hundreds of high-resolution CT images to distinguish the cystic lesion from emphysema and to distinguish also, this is another paper on thousands of slides tested to distinguish diffuse cystic line disease from emphysema, but also distinguish Lyme from histiocytosis, Burgos-Duby syndrome, and other disease. So this is a possible way to improve the diagnostic accuracy of interpretation of high resolution CT with an accuracy that is very close of expert radiologist. In parallel, several additional biomarkers are being investigated. Matrix metalloproteinase, particularly MMP9, are increased in serum and urine of Lyme patient. However, they are not specific. And TSC2 loss of heterozygous can be detected in circulating and urinary cells from Lyme patient and decrease after sirolimus treatment. But we will see that they are also non-specific. Recently, very recently, by a panel of experts in Lyme, one is Vincent Cottin, it has been published on chest that plasma MP8 levels were elevated significantly in Lyme patient and were correlated negatively with FEV1. So this is another important area to be further investigated. This is a study we conducted some years ago on TSC loss of heterozygosis. And as you can see, we compare healthy volunteer to Lyme patient and to pulmonary lung cell endocytosis. And unfortunately, in serum and urine, loss of heterozygosis was also present in patients with histiocytosis. Probably the presence of LOH TSC2 in pulmonary lung cells and represent something confirming the tendency to develop chromosomal abnormalities in neoplastic disease, and also pulmonary lung cell histiocytosis is a clonal neoplastic disease. More recently, we also investigated serum microRNA, and we performed a two-step study who sorted that Myrna 302 20 family members associated with Myrna 1972 and Myrna 186-5P may improve identification of patient comparing using single Myrna, supporting the idea that a combination of serum microRNA can be more effective in detecting complex disease like LAM than a single marker. The level of these Myrna were particularly elevated in LAM patients with low VGDF levels, suggesting that this biomarker could be complementary for achieving a diagnosis in this subgroup of patients. Glycoprotein non-metastatic melanoma protein B is expressed in LAM cells, and is expressed, its extracellular domain is released into serum. Its expression depends on mTOR1 signaling and promotes the growth of TC2 null cells in vivo. Serum level of this marker are increased in LAM patient and decrease with the use of mTOR1 inhibitors, making a potential marker and even a therapeutic target to be considered. So in conclusion, obtaining a definite diagnosis of LAM is important because it affects quality of life and therapeutic decision patient must face, and also some important aspect of life like pregnancy. Although the guidelines provide clear diagnostic criteria in clinical practice, the diagnosis is not always immediate. In the future, the use of artificial intelligence could help with interpretation of CT scan, even by less expert radiologists and centers. The implementation of biomarkers would be useful to achieve definite diagnosis also in patients with negative level of VGFD. New molecular and translational insight in the pathogenesis of the disease will be of help in finding new therapeutic approach and hopefully a definite cure for this disease. Thank you.
Thank you very much, Sergio, for this very nice and clear presentation. I invite you to wait until the next presentation to have the discussion all together. So I'm going to call you back in 30 minutes, more or less. Y ahora es mi placer presentar al profesor Vincent Cottin, que es el coordinador del Centro de Referencia Nacional Francés de Enfermedades Raras, donde aparte de la linfangioliomatosis, pues hay otras también enfermedades raras y hipertensión pulmonar y enfermedades intersticiales. Pero bueno, hoy es un día especial porque sois las protagonistas y creo que cada vez no sois raras. Esta enfermedad no es rara, cada vez hay más gente, la está diagnosticando mejor, como veis que es difícil, pero ahí vamos. ¿Y por qué? Pues porque nos van a hablar del tratamiento, a ver qué tenemos a día de hoy, qué novedades y a quién y cómo hay que tratar. Gracias.
Muchísimas gracias. Can I use this one? Does it work? Yes. Sorry, I'm not ready to present in Spanish. But I'll try to take questions in Spanish. First of all, the first disclosure is I'm most presenting the present, and hopefully many of you know already what I'm presenting, but some background will be useful for the discussion. And I don't have really big news for the future yet, because unfortunately there is not yet a major step in the progress of treating this disease. Hopefully that will come. I found my old slides, and it's a pleasure to come back because I realized that I was here around the same place in 2012. discussing the guidelines that Sergio has presented, or part of it, that had just been published at that time. And, well, this time it works. I don't have any disclosure except that I'm chairing the scientific committee of the French association, which is called FLAM. So first of all, when we treat patients with LAM, I think it's good to be treated and seen for diagnosis in an expert center. This is the map of France, and we are progressively increasing the number of expert centers so that patients can find an expert center with not too much difficulty. Because it is an expert diagnosis to be made, and the decision to treat or not to treat and how to follow treatment sometimes is not so easy. It's not that complex. There is a single drug to use, but we want to treat patients who really need treatment and not treat patients who possibly don't really need a treatment. And there are guidelines. I suppose in Spain there are also some Spanish language documents that can be used to guide the treatment, and this is the example of the French guideline. And there is part of it which is for the treating physician. So it's important that you be seen in expert centers, but also that the treating physicians, who of course is not a specialist of that disease, is also informed of the diagnosis, where to find some easy and relatively short information, and can have answers to questions about treatment. So I'll discuss, of course, sirolimus, the treatment indications, some of the long-term effects, and some discussion about potential future treatment. But I knew that Sergio would insist on the relevance of making a good diagnosis, but I'm doing that again because what we want is to make sure that the patient that we are facing does have a lymphangioliomyomatosis before we even discuss any treatment. And for example, these are two CT scans from two different patients from a clinic. They really look very similar. You have cysts and you have some normal lung. If you look carefully, you would see that some of the vessels are not really exactly the same place as compared to the cyst. Here you have no vessel, for example. Here you have some vessels, but they really look very similar. But they are different diseases. On the right you have LAM, on the left you have an even more rare disease, which is light chain deposition disease. And that requires some additional tests, of course, which I won't go into the detail, but that's why to have a good criteria for the diagnosis of LAM is so important, is that you have some mimics. And there are many cystic lung disease. Some of them don't look like LAM, but some may look like LAM. And so we are using that algorithm to exclude things that don't correspond to LAM, to finally have a good diagnosis of LAM. So I'll stop with the diagnosis, but really I insist because if we don't start on a good basis, then we end up in the wrong place. So what are we trying to do when we treat LAM? The main goal is to prevent lung function decline. What we want is that patients with LAM live a normal life, don't think about the decline in lung function, and after 5, 10, or many years, have an acceptable lung function. That's the objective. And with time, we follow FEV1, so the maximum air that you can expire during 1 second, which is the best reflection we have for the airflow obstruction, so the consequence of LAM. And usually when the diagnosis of LAM is made at that time, in a young female patient, the lung function is still relatively good. Sometimes it's lower, sometimes it's higher. And the goal is to follow if there is some decline and then to slow down that decline. And very often there might be some decrease in the rate of decline after menopause, but this is not always true individually. It's true in statistics, in big numbers. Individually, it's not always true. Sometimes the diagnosis is made with a very normal lung function, and some patients with only a few cysts remain with a normal lung function. It's normal to have some decline with aging, right? But that patient up there would definitely not need any drug therapy. And sometimes the decline is faster. And that patient in blue would need a treatment because otherwise you have some decline in lung function. And the objective here for treatment is to slow down the decline and make sure that from the time we initiate treatment here, the decline is parallel to a normal decline. That's the objective, so that over time, even after some aging, the lung function is still acceptable. And some patients have, unfortunately, a very more rapid decline here. And again, we want to initiate treatment not too late so that we stabilize or almost stabilize the lung function. That's the goal. But unfortunately, with the treatment, sometimes the goal is a little bit difficult to obtain, and there is still some decline despite therapy. But at least you understand, I hope, what the objective is. So first of all, not everybody needs a treatment. Remember in my previous slide, there was the blue line, patient with almost normal lung function. That patient doesn't need a drug therapy. That would bring some adverse events, almost certainly, at least some, but no benefit because the lung function is good and there would be no real effect. So if the lung function is normal or only mildly impaired, what is suggested is to have supportive measures to treat the complications and to monitor the observations. So supportive measures needs education, information, making sure that you don't put yourself in a situation at risk, and treat the complications, that especially the pneumothorax. In case there is a pneumothorax, then of course we treat the pneumothorax, but it doesn't necessarily impact the decline in lung function. Usually it doesn't. Once you have been treated, then the lung function is back to what it was before. Monitor observation means to be seen clinically and have some serial lung function measures to make sure where you are on the line of a change in lung function over time. So when we want to treat, why do we use CO limits? So Sergio has presented that already, but I'd like to come back on the fact that we're using something that is against proliferation of cells, where we have a disease that is mostly cystic. You've seen the chest CT scans. The problem is that we have cysts. The round black holes are cysts, so holes in the lung. And we're treating a disease with holes in the lung with a drug that prevents proliferation of cells. So why is that? Is that because if you magnify, so this is a CT scan, if you take a cyst like that and you look at it on the microscope, so this would be a smaller cyst, of course, we are looking at magnification on the microscope. Around the cyst, or at the edges of the cyst, you have these areas like this one or that one. And if you magnify it, then you have an islet, a proliferation of LAM cells. And these LAM cells produce proteases that are enzymes, proteins, that degrade the normal lung parenchyma, which is around them. So these cells are actually proliferating, but they're also producing what destroys progressively the lung and is making the cysts, the holes in the lung. That's why we target these cells with anti-proliferating drugs. And in addition to destroying progressively the lung and making the holes, these cells also travel in the body, and they can make new areas of LAM cells in the lungs, and sometimes also travel to the kidneys and produce some angiomyolipomas, AMLs. So they transit like LAM clusters, so clusters of LAM cells via the lymphatics, and they may travel, enter the circulation, and end up mostly in the lung, but also in other organs. And by using CO limits, we also probably decrease the circulation of LAM cells. So we have some LAM nodules, and I've I've mentioned that these nodules are producing the metalloproteases, the enzyme that are making the cyst. So this is a bit oversimplistic, and I see Dr. Puhala find it probably oversimplistic, but I think it helps understanding why we are treating a cystic disease with sirolimus against proliferation. So you have seen this pathway before. That was a different diagram, but the same pathway, where this is the periphery of the cell, the membrane of the cell, and inside the cell you have a number of different molecules which make some signaling. That is, one molecule is hitting the other one, which is hitting the next one, and that pathway is producing a signal in the cell to tell them to proliferate or to do other things. And by the mutations there are in TSC2, that patients with LAM carry some mutations, usually in somatic mutations, that is, in the body, especially in the lung, or germinal mutation that can be inherited in the case of tuberous sclerosis. These mutations activate the mTOR pathway, and so mTOR is overacting and driving cell proliferation. And sirolimus is inhibiting mTOR here, so blocking the downstream effects of the mTOR activation. Sirolimus and rapamycin are the same. Rapamycin is the natural name of a drug that actually comes from the nature. Everolimus is a close relative to sirolimus, so same family of drugs with almost similar effects. The difficulty is that, in fact, it's a bit more complex, and that's why we need researchers to still continue to work on that, because this very simple pathway that I've showed is an oversimplification of what the pathways are. And you can imagine that when you hit something in that complex pathway, you may have some side effects or areas that you don't expect to are increased or down regulated, and it's sometimes a bit difficult to really control everything. That's why we still need some research to possibly identify additional targets next to mTOR just itself. So is sirolimus effective? The answer is yes. So we have known that for 15 years or even more. And that's the best trial we have for LAM. It's not a huge number of patients, but it's the highest number of patients who have been enrolled in a trial. 89 patients were randomized, meaning that half were receiving sirolimus and half were receiving placebo, no drug. Nobody knows it until the end of the trial when we analyze the results. Patients who receive sirolimus, they have, after 1 year, stable FEV1, and patients receiving placebo have a decrease in FEV1. And the same is true for FVC. I'm going to show you in a minute what this corresponds to. And so another way to representing it is that when you receive sirolimus, you have stabilization of FEV1, sometimes some slight increase in FEV1, but after 1 year, you're almost the same place where you were initially, whereas patients receiving placebo had some decline over 1 year. And then from now on, from this dotted line, treatment was stopped, and you see that sirolimus did not prevent the further decline. So when you stop sirolimus, then the benefit is stopped, and the disease may start again to progress. That is the reason why we advise for long-term continuation of sirolimus if the tolerability is acceptable. In addition, there was a decrease in VGFD level, especially patients who had very high VGFD level at initiation had a decrease of their level during the trial. And it seems that patients who had very high levels also benefit most from sirolimus. So sometimes we say that if there is a very high level, there is a greater chance of a benefit from treatment. But this is a post-hoc analysis of this trial, and it remains to be really demonstrated. So we're using FEV1, you see, to monitor the progression of disease. I'm sure everybody is familiar with spirometry, but we do spirometry, we measure that curve. So you ventilate, you just breathe normally here, then you take a good inspiration, maximal inspiration, and then you exhale as fast and as completely as you can. And over time, this is force vital capacity, so the maximum volume of air between full inspiration and full expiration. And what you can exhale in 1 second is FEV1. So FEV1 is that volume here, FVC is down to there. And this is the residual volume that you cannot really mobilize, that stays in the lungs even when you exhale completely. So that's why spirometry is important, because that's the measure we have to follow the progression of disease. Problems. Well, the problem is, as you may be aware of, there are some adverse events of sirolimus. Fortunately, not everybody gets all of them, but it's quite usual to at least get 1 or 2 of them. Acne or mouth ulcers are very frequent. There might be some nausea or abdominal pain or diarrhea. Some patients need to treat or to have some additional drugs for increase of triglyceride or hyperglycemia or cholesterol. And we also monitor the blood levels because there can be some cytopenia, some anemia or decrease in the white cells. So that's why we need some education. And we are doing that today to try to inform about how to manage the drugs. That's very important because when you have a drug that creates some adverse events, you have to inform in advance and also to manage these adverse events and try to reduce them as much as possible. So we have to accept that the drug is not perfect, but then accompany patients to manage as best as we can the adverse events. And we do that. This is the photos taken in a training session for patients in Lyon, organized by a colleague in the department. And she covers treatment, but also symptoms of LAM, how to live with LAM, what the disease is, and so on. We've done a survey based on the SNDS, which is the healthcare database that we have in France that covers almost everybody in France, which is covered by the Social Security. And that's a good tool to know how many patients have a disease and how many patients receive some treatment. And over the last years, 208 patients with probable diagnosis of LAM were receiving sirolimus. And we could identify some adverse events. So we are not sure these are adverse events of sirolimus for a patient with LAM, but it's probable that it is the case, or at least it is probable that patients had LAM. They were receiving sirolimus, and we can assume that possibly there is a link with their treatment. So cytopenia do occur in a few patients. Some may experience pneumonia, so of course they may experience pneumonia without sirolimus, but they had some infections, opportunistic infections or treatments to lower the lipids also in a few, and some high blood pressure or hospitalization. Here it's more difficult to make a link between the treatment and the event. Well, we've seen the effect on lung function, but there are additional benefits of sirolimus in patients with LAM. First of all, there is, and I'll show you examples, a good efficacy on the lymphatic complications. These complications are not so frequent, but they are difficult to treat, or they were difficult to treat until we were using sirolimus. Chylous effusions in the pleura or ascites. Lymphangioliomyoma, we usually don't need to treat them, but when we do, then sirolimus is very effective. Or lymphatic congestion syndrome, I'll show you an example. Sirolimus is also effective on the AML, the kidney benign tumor. It does reduce the risk of mortality from observational data that have been published in several centers. it might reduce the risk of pneumothorax. So in patients who have recurrent pneumothorax, of course, treatment is more based on surgery, but medical treatment may also help to reduce the frequency of the relapses. On the long term, we have some data that shows that it can be well tolerated and leads to stabilization of the lung function on the long term. And there are also some data showing that lower dose might be effective. We don't know exactly how, but some patients who were not really well tolerating the normal dose had a reduced dose and still was efficacy with the reduced dose as compared to no treatment. So we have to identify what the target is. In general, the target is to reduce the lung function decline. As I mentioned initially, you have some various CT scans here, more severe, less severe, but the objective is the same, is to prevent the lung function decline. But in some patients, the objective might be because we have problematic pneumothorax relapsing, or because we have problematic chylothorax. This is a pleural effusion of chyle that can be prevented or treated with sirolimus. So this is chylothorax. With sirolimus, it disappears. This is the congestion. So this is probably a lung that is, so it's not an infection, it's an accumulation of chyle in the lung itself, not in the pleura, but it can be reduced by sirolimus. You see the lung is clear here. And there is also a benefit on the lymphangioliomyomas or in the kidney tumors that would disappear here. Another example of the pulmonary congestion, a quite severe one. The patient had respiratory failure, and with sirolimus, you had a clearance of the lung. The long-term effects are represented here. So you see that this is lung function, FEV1 over time, 1, 2, 3, 4, and 5 years. Some patients have a clear benefit in orange here. They have an improvement in lung function that really stays over time. Some in red, very good result also. Some in blue, some slight decline, but probably parallel to a lung function decline that you would have in a normal, in a healthy subject. And some in green are more problematic, showing that you have a minority of patients who would still have a decline in lung function despite sirolimus. The bars here are the confidence intervals, showing that in fact there is high variability from one patient to another in that group. So we really have to have a look individually and draw the line and see where the patient is in terms of lung function decline. Sergio mentioned that. This is from another study, I believe, from Spain, showing that historically there was some mortality due to LAM, or patients needed to have lung transplant. So with time you have fewer patients who were still alive and not yet transplanted. And this is the contemporary, so the current period, where it has become much less necessary to use lung transplant, which of course is still a very important treatment, but the experience shows that it has become a bit less necessary, or in the minority of the patients, fortunately. So now, what are the recommendations telling us? These are the international recommendations from the USA and Europe and Japan. Treatment with mTOR inhibitors, so sirolimus and everolimus, are recommended for patients with LAM with abnormal or declining lung function. And for selected one, problematic chylous effusions, we suggest sirolimus. So sirolimus is recommended by international guidelines. Indications means who do we treat? We treat patients who have FEV1 less than 70, who have a rate of decline more than 90 mL per year on average, because that's 3 times the normal decline. So if you have a decline that is 3 times faster or more than the normal decline, then you may need treatment. Sometimes treatment is initiated for other reasons, such as alteration of gas transfer or desaturation, hypoxemia, chylous effusion I've mentioned, or the kidney tumors because it works well on them. Now, we tend to use treatment earlier and earlier because we have more experience. We see that if we manage it, it can be well tolerated. So the trend is to treat earlier, but to discuss in a team in a specialized center. Treatment is usually initiated at 2 milligrams per day, and we do some blood draw to make sure that the level is appropriate. When there are adverse events, they wean off very often after a few months, even the drug is continued. For example, muscle cells in general, they tend to disappear or be less prevalent after 2 or 3 months of treatment for some reason. And so if tolerability is good, we can continue as long as it is tolerated. Importantly, it's good to be vaccinated, if possible before sirolimus, but you can still get vaccinated during sirolimus treatment. The treatment is avoided in case of pregnancy or breastfeeding. It's not a formal contraindication, but it's preferred not to have it in terms of pregnancy. And pause in case of severe infection, pneumothorax or surgery, because it may decrease wound healing. So it's better to pause for a couple of weeks if there is a surgery. And there are drug-to-drug interactions, so it's exactly the same as in patients who have had a transplant. We have to be very aware of drug-to-drug interactions. So now the future, the trials, what is in the pipeline, what is the current research? First, there are 2 trials not yet published, conducted in the US networks. The MILD trial, which is trying to treat earlier. So I've already mentioned that the trend is in expert centers to try to initiate treatment a bit earlier so that you even prevent better the decline in lung function. This is currently tested in a clinical trial. The MIDAS trial is an observational study. So it's not really a trial, it's a study observing the long-term efficacy and safety and efficacy of sirolimus. So this is prospective, so we'll know more about the long-term tolerability. Other treatments, you may have heard of doxycycline or hormonal therapy. The answer is very clear. The guidelines, international guidelines, suggest not using it. So not using doxycycline and not trying to use hormonal therapy for LAM because there is no clear benefit of these treatments. So what to do in case sirolimus is not effective? You've seen the lower line where there was still some decline in lung function despite sirolimus. Well, first of all, it probably affects a small proportion of the patients. Less than 10% are refractory, really, to sirolimus. Some don't tolerate it, but among those who tolerate, refractory cases are few. Then we can try and increase the dose if it's tolerated. We can switch to everolimus. It may work, it may not. It's a very close related treatment, so it's not really always working, but we try that. There are some clinical trials, and of course, lung transplantation, you'll hear later about it. And this is a summary of the trials that have been published. Most of them since the publication of the MILES trial. And remember the MILES, there was 89 patients. Here you have 10, 23, 13, 12, 25, 30. So much more earlier and preliminary trials that none of them clearly demonstrated a benefit of treatment. And there were various drugs which were tested. Simvastatin, which is a cholesterol-lowering drug, but that was used because it thinks to be an inducer of cell death that could trigger the death of LAM cells. Doxycycline, it's an antibiotic, but it also inhibits metalloproteinases. Hydroxychloroquine inhibits autophagy, and Sergio mentioned it. This is an anti-inflammatory, this is a hormone regulator, And I'll speak about nintedanib, which Sergio conducted a trial on. This is the study published by Sergio Harari a couple of years ago. So it's a phase 2 open-label study, meaning that every patient knows what they are receiving, and all of them did receive the drug. So you don't have placebo, you don't have control group. So it's easier to conduct because it's more acceptable for the patients to participate. But then the level of evidence we get is lower because in the end, it's difficult to make sure that really the treatment is doing better than nothing because there is no good comparator. However, 30 patients received the drug, and they were either not treated because they could not tolerate, and some were really naive of treatment, and some had progressive disease despite sirolimus. And you see the individual lines here. In general, there was a trend for stability. Some had a decline, some had less decline, but in general, these patients had a stable disease over at least 1 year, sometimes 2 years, despite the fact that initially you had some with progressive disease despite sirolimus. So since then, this has become a possible additional therapy we can use in patients who have progressive disease despite sirolimus, but it is clearly second line, and the level of evidence is lower as compared to sirolimus. The drug is already approved for different disease, pulmonary fibrosis, so we know it well. And the adverse events are nausea, diarrhea, quite frequently, and abdominal pain. I think I'll skip that. We can come back if we want in the discussion, but these are examples of the smaller trials with fewer patients. This is the TRAIL, for example. This is a drug used for breast cancer that was tried in a few patients, but you see it's very few patients, and you have no big change in patient receiving placebo or letrozole, so in the end, it doesn't really inform us so much. And this is the same for doxycycline. You see, even with placebo, there is not so much change, so patients were not a great number of patients to treat or followed long enough to really make a good conclusion. Maybe more importantly, because that trial is conducted in Spain, the LORALAM trial, which is coordinated by Professor Maria Molina in Barcelona. Loratadine is a histamine receptor antagonist, but there is some rationale biologically to suspect that it might have some effect in patients with LAM. This one is randomized, so there is a placebo arm. So in the end, we'll know for sure whether there is some signal for efficacy or not, which is good. And enrollment target is 62 subjects. Half of them will receive the drug. And you see the endpoints, the safety, the lung function decline are the main objectives to follow with this trial. And if you go to the LAMP Foundation website, you will see also the LAMP2 trial. So the LAMP Foundation is the patient association in the US. And they are conducted a trial, which is a phase 1 trial, still randomized, very early but randomized, with imatinib, which is a drug coming from the cancer field, which targets tyrosine kinase such as nintedanib. So similar to nintedanib, which I mentioned earlier, this is another tyrosine kinase inhibitor currently in a trial in the US. So what really is the future? I don't know, of course, and probably this afternoon you'll hear more about the progress of the research with Dr. Puhana. And but I'll mention these titles because one of the possibilities for the future would be immunotherapy. You may have heard of immunotherapy in the cancer field. This kind of treatment has dramatically changed many management of cancers, and it's under consideration in patients with LAM. There are not yet trials, to my knowledge, for LAM, but it might come in the future, in 5-10 years maybe. And what you do with immunotherapy is trying not to target the LAM cells, but to target the neighboring cells. And this is a work that has been conducted by Remy Disler, who is a young fellow in my department. And he went to Lisa Hensky lab. And the scheme from this paper is that here you have the LAM cells, but next to it you have macrophages, so normal cells, which are slightly altered by the context of LAM. And instead of targeting the LAM cell, you can modify or target the macrophage itself and try to have the macrophage influence the LAM cells which are next to the macrophage. And you can also do that for lymphocytes or other kinds of cells, the white cells. They are present in normal in the body. But the idea is to modify the surroundings of the LAM instead of the LAM cell itself. It might be a complement to sirolimus, for example. So I'll stop that. So you've heard, don't forget that monitoring, observational monitoring, very often is the option of choice. So if you don't receive a treatment, don't think, well, I should receive a treatment. Maybe not, sometimes, or quite often. Observation is the best option in case the lung function is relatively preserved. In case we need a treatment, sirolimus is effective and safe. There can be some adverse events, but it's considered a safe treatment. And when indicated, it can be continued for as long as it is tolerated. And sometimes we can lower the dose. For example, use 1 milligram per day only instead of 2, in less severe cases especially. Thank you for your attention.
Gracias, Sergio. I invite you to join us for the discussion. I think we have learned a lot. I have learned a lot today in the present and the future. Creo que I'm going to switch until the question to Spanish, that is my language. Creo que es el momento de que hagáis todas las preguntas, ¿no? Sin ir más lejos, supongo que estará aquí una de las pacientes que me escribió un mail que va a venir al hospital, porque es verdad que el tema del diagnóstico es complejo, ¿no? Porque muchas veces tenéis que ir de hospital en hospital hasta que os dicen un diagnóstico. Hemos visto claramente en las guías, hay un diagnóstico de posible linfangioleiomyomatosis, un diagnóstico definitivo de linfangioleiomyomatosis, y antes de valorar un tratamiento, como han dicho, pues hay que tener un diagnóstico certero, sobre todo porque esta enfermedad tiene afortunadamente un tratamiento que hemos visto mucha evidencia aquí y para qué sirve no solo la función pulmonar sino más cosas, pero también las otras entidades que entran en el diagnóstico diferencial, algunas también tienen tratamiento específico, con lo cual creo que el diagnóstico es fundamental. Sergio, no sé si estás conectado, si pueden poner la imagen. Yes. So Sergio, I'm going to speak English. I know Italian for the moment is not good for me, but my daughter loves Italian. So Sergio, we can see you. Thank you very much for your presentation. So I would like to, I think you give a clear example what important is to a patient with suspicion of lymphangioliomyomatosis go to an expert center. And also it's important to work in network in every country because we need different expert centers around a whole country. So what do you think is the main problem nowadays for a definite diagnosis of LAM or a good diagnosis of LAM, at least in Italy? And how do you think we can improve that, being LAM not an ultra-rare disease anymore, but a rare disease?
Well, I must say that in Italy, we are the largest center, and most LAM patients are referred for at least 1 second opinion to our center. However, the problem is particularly, as I mentioned in the 2 clinical cases, the evaluation of CT scan that can mimic cystic pattern like LAM and can be sustained by other cystic line disease, as also Vincent mentioned, for example, light chain deposition and other rare disease. So I think one key point is always the evaluation of high resolution CT. And I must say that since the comic pandemic in 2020, we are much more comfortable to share images, so also simple by WhatsApp or other application or through transfer via web that can help us sometimes colleagues and support them in the evaluation of CT. The other problem is VGDFD, because if it's not done in an expert lab, the values are not really accurate. So it has to be made in an expert lab. Say that there are always a gray zone of patient where it's difficult to make a final diagnosis, and in that case, I think really we need to have a referral to an expert center and sometimes the best thing is to consider wait and watch, and if this way is not viable for the severity of the diseases of Sambat, also invasive procedure. However, I must say that the number of invasive procedure performed, at least in my country, has decreased dramatically. It's very, very rare that the patient has a surgical procedure to make the diagnosis.
Thank you, Sergio. I think that invasive procedures to decrease is the tendency everywhere, even in Spain, because guidelines try to make a non-invasive diagnosis with a lot of tools. And here I think it's also important that pulmonologists are sending to other colleagues that they know from expert center. Even your own pulmonologists are sending to ask for a second opinion. And in France, you are very well organized. And do you think that it's important, all that you have, the guidelines on national level, we don't have that, guidelines on national level to teach or to inform our colleagues, not only pulmonologists or expert centers, but other pulmonologists to be aware of the disease?
Yeah, I think the guidelines are important. In France, we're not very good for languages and foreign languages and even English. Now, that's true. I don't know. I cannot judge for Spain. But many French physicians would not even read so easily if it's in English, or would not take the effort of reading really fully the guidelines if they are in English. So sometimes the guidelines in the local language can adapt to the local situation. For example, if a test is not easily available or is very expensive, you make some local adaptation. But the very obvious is that the local guidelines are in the local language, and it's a help for many. Your question was about the expert centers. Yes, we have a very visible network of expert centers in France, but still, when we've done the survey in the French healthcare database, the SNDS, we found that many patients were actually seen outside of the network, and the proportion was close to half. So I advocate for patients being seen at least once, such as in Sergio's center, for example, in Italy, in an expert center to validate the diagnosis. If you come back and say, well, this is the same diagnosis as change, it's a very positive outcome, because at least you have a secure diagnosis. And if the diagnosis is changed, obviously it's a major change. And the final thing I would say about the diagnosis maybe is, at least to me, the secure diagnosis is crucial when we discuss a treatment. If the discussion is monitoring, it's a bit less important. We can accept a degree of uncertainty if the outcome is just follow-up. I'll see you in 3, 6, 12 months with the lung function, and if nothing has changed, we continue monitoring. Then if there is some 20% uncertainty in the diagnosis, to me it's acceptable. If the outcome is we initiate a treatment, then we definitely need some certainty in the diagnosis. And we have to make sure, like Sergio was mentioning, that it's not only reliable, it's not only related to VGFD level, because like any biological test, you have some false negative and some false positive results.
Sergio, one difficult question for you regarding diagnosis, and I think we have question also in the chat. I'm not sure how I can read it. I'm gonna try. And about cryobiopsy, because invasive procedures, we have surgical lung biopsy, but now in ILD, as you know, especially in Italy, a lot of cryobiopsy is taking the place to replace surgical lung biopsy. How do you think it's going to change that, especially in the cases of possible lung or when the other variables are not useful to make the diagnosis?
Actually, for Lee, I must say that we had a previous experience. We published it many, many years ago on transbronchial biopsy on pulmonary lung astrocytosis and LAM. And the sensitivity was good for LAM and low for pulmonary lung astrocytosis. And this is for the histological pattern of LAM. So the diagnosis also in small sample can be made. Regarding cryobiopsy, I do cryobiopsy, I perform cryobiopsy in ILD. However, I must say, finally, the number of cryobiopsy we perform, I am speaking generally, is very limited compared to other centers. So if you do a clinical radiological multidisciplinary approach, the number of uncertain cases is quite limited. Coming to LAM, I think if we need an invasive procedure, we can do cryobiopsy. I would prefer cryobiopsy compared to a surgical lung biopsy, certainly. But I must also mention that I perform cryobiopsy since I think 10 years, and I never performed one in LAM patient.
Thank you very much, Sergio. We have questions in the room. Don't be shy, no seáis tímidas.
Or comments.
O si no, comments or about everything. Diagnóstico, tratamiento, what you want.
A ver,
Yes.
ahora sí. Buenos días. ¿Es posible un diagnóstico certero sin una biopsia?
Is what we were talking about, Sergio. They ask if it is possible a certain diagnosis without a biopsy.
Yes, of course. We have guidelines with some criteria I mentioned in one slide, so we can have a certain diagnosis, a definite diagnosis on the basis of the pattern of CT scan plus one of the criteria mentioned, for example, the presence of angiomyopathy, lymphangioma, level of VGFD over 800, or the presence, of course, of tuberous sclerosis.
Como te ha contestado, creo que es importante seguir las guías. Por eso digo que cuando va alguien y ve un escáner con quistes y le dice, pues tienes una LAM y no es un centro experto, quizás no hace todos los otros puntos, que es ver si tiene angiomiolipomas, ver si tiene los niveles de VGF-D, ver si tiene quilotórax, si tiene otras características que permiten con un escáner compatible con una linfangioliomatosis. Si tienes una de esas otras características, se puede hacer un diagnóstico definitivo sin biopsia. Entonces, eso es importante a la hora de no someter al paciente a pruebas que son invasivas y que pueden tener pues un impacto, ¿no? Entonces, yo creo que es importante justamente los centros expertos para guiar todo esto, porque muchas veces en otro centro van directamente a hacer algo que no es, vas a tener el diagnóstico, pero quizás con un poquito más de riesgo, ¿no? No sé si tenéis algunas preguntas de tratamiento, si no, yo sí tengo preguntas sobre el tratamiento, porque creo que cuando a alguien le diagnostican una enfermedad rara o una linfangioliomatosis, pues hay mucha angustia, ¿no? Y sobre todo dice, tengo que tener un tratamiento ya, porque hay, ¿no? Y hay información de que hay tratamiento. Ha quedado claro en la presentación, pero creo que tiene que quedar claro aquí que hay un tratamiento y cuándo tratar, y que no todas las pacientes con diagnóstico de linfangioliomatosis necesitan inmediatamente un tratamiento. Y ahora llegaremos a esa parte del estudio Midas, me parece, que no lo conocía, de ver en qué caso estáis haciendo ese tratamiento early en patients with preserved lung function, ¿no? Para que Sergio, we were talking about when to treat, who to treat, and not all patients with lung.
Yeah, well, I don't have the results of that study, but clearly it's a study which enrolls patients with a definite diagnosis of LAM. So you already have the second criterion, like you mentioned, like the typical CT scan, even with fuses, because it's early disease, but it's compatible or suggestive of LAM. And a second criterion, which can be a biopsy or can be the presence of AML, for example, that's the most frequent, or a very high level of VGFD. And those patients are enrolled if they agree, and then they're randomized between receiving treatment, sirolimus, versus placebo. So the only difference as compared to MILES is that you target patients with early disease, meaning almost preserved lung function. I don't remember on the top of my head the criterion on the lung function, but clearly they must have close to normal lung function, whereas in the MILES trial, in general, lung function was already altered with FEV1, I think, below 70% of predicted value. So initially, when we didn't know whether the treatment was effective, the priority was to treat patients who were more at risk of respiratory failure, and so the MILES trial targeted patients with already altered lung function. And now that we know that the treatment is effective in that situation, the objective is to evaluate whether it's also effective in patients with early disease. And I'm speaking about efficacy, but also tolerability. It might be that the result is that, yes, it is effective, but in the end, it prevents only a few milliliters in patients who have almost normal lung function, but they still have adverse events of the treatment, and it's not worth it. So we believe it's worth it, or they believe it's worth it, because they've launched the trial, but we'll have to wait for the results to really see balance, the benefit, but also the inconvenience of the trial to see whether it's worth it initially in the diagnosis. And currently, if a patient comes with a very diagnosis of LAM, I don't treat. I don't know what Sergio does or you do, but I don't propose treatment so early if the lung function is still normal, because I don't know on which decline the patient will be, and then I propose observation, monitoring, and if we see some decline, then we discuss and propose to initiate treatment.
Thank you, Vincent. Sergio, what is your experience treating or not treating patients with almost normal lung function.
I fully agree with Vincent. We do not treat patients with very low abnormalities and lung function, particularly if they are asymptomatic. We follow them over time and we treat if they progress. The study we done on nintedanib, where the goal of the study was just to consider patients with progressive disease. And so differently to mild trials, we study only patients with progressive disease or naive or despite treatment with sirolimus. I think an important area of this investigation is this one, so to find a second-line treatment for patients that have or toxicities or progression despite the first-line treatment with TOR inhibitors, sirolimus or everolimus. And the other open question, and we are unfortunately far to find an answer to this, is to find a definite cure.
I think we all want that for every disease, especially for LAM, especially today. And I think it's very clear because there is a treatment. We have criteria for treatment. So those patients, or almost those of you that are not receiving treatment because your physician thinks that you don't need for the moment a treatment, be calm, because there are not evidence now for putting treatment if you are asymptomatic or with normal function y en español. So, tranquilos, sabemos que hay tratamiento y cuándo indicarlos. Es importante, obviamente, los centros expertos y que manejan esta enfermedad, y es importante saber que si estáis asintomáticas, con una función normal, el seguimiento es importantísimo para definir cuál es el momento en el que se puede necesitar un tratamiento o no. Así que, y the last question or the other question for both of you is, and you already mentioned, Sergio, is patients that are progressing. We are not going to talk about transplant because Berta y Álvaro are gonna, y Rosalía, I think online, are gonna have a whole session for that. Those patients, this minority of patients that still progress under sirolimus, what are you doing in your clinical practice with the evidence? Of course, the more, even if it's a negative trial with nintedanib, there is some quite evidence on that. What are you doing in your clinical practice with that?
Well, first of all, coming to what you said before, it's important for patient to know. I'm sure Vincent has the same experience. Sometimes we see patients that have now a diagnosis of LAM for occasionally for a car accident, for anything, and they are symptomatic. We have the opportunity to see a CT scan performed for other reasons 20 years ago, and it is exactly the same. So we know that a proportion of patients do not progress and do not need treatment. And so this is very important. The other issue, what to do when a patient develops progression? Well, our study demonstrated that the stabilization of pulmonary function test during treatment, and our goal was to improve pulmonary function test, so we missed what was the primary endpoint. In the real life, actually, we try first to increase the level of sirolimus, the posology, or shift eventually to everolimus. Sometimes we are considering the shift to nintedanib, and however, now we are thinking to a new trial, but we are still still developing, trying to evaluate the combination of the interim and sirolimus.
Well, I would say that in general, in LAM, there is no emergency to treat. So in case of doubt, when you hesitate to initiate treatment, there is always a possibility to wait, to think about it, and to see your doctor a bit later and have another lung function done. And sometimes the next lung function is a bit better, so you say that in fact you had a flu last time and the lung function was not so good for that reason. So in case of doubt, monitoring longer is very helpful. In medicine, the trend is very important, whether it's down or stable, it makes a huge difference.
And for combination with...
But don't wait forever.
And for progression, what do you do when there is progression?
Well, I follow Sergio's opinion. So now that we have seen the results, we know that nintedanib is safe in patients with LAM. So it was 30 patients, but it's still a good trial for that very rare disease. I would try and combine with sirolimus. So if a patient is tolerating sirolimus well, but the lung function is declining significantly, I discuss with them with the addition, the combination with nintedanib. But this is really a handful of patients that we have treated so far, and I think it really needs some discussion in the center with colleagues to make sure that we are not missing anything, missing a risk of that treatment, for example, because there is a history of gastrointestinal whatever. And also with the patient to make sure that they understand this is not an approved therapy for LAM, which is different from sirolimus, which is approved, and they understand the expected benefit and the possible adverse events of that treatment before any decision is made.
So I think you have given very important messages. We are just arriving to the end of the session. I don't know, no tienen ninguna pregunta. Yo creo que ahí atrás hay alguna pregunta. Y en el chat es que no lo puedo leer. A ver si lo puedes leer. They are going to make some question from the chat that I can't read, but they are going to read it for me. Cuando quieras.
Okay. Gracias. Bueno, pues tenemos una primera pregunta. Dice que está relacionada con los procesos de autofagia y los macrófagos. Si estos procesos están más avanzados en tratamientos de cáncer de pulmón y si hay relación con estos centros para poder aplicar los avances en LAM.
Bueno, it's a difficult question because I don't know who is connected, but he or she is very expert regarding about asking about macrophages and how this is advanced for the application as on lung cancer, but in LAM. So, Sergio, you have any idea of that, or after Vincent? I don't know.
No, I do not have any news about investigation of trial. There are several trials that have been done on autophagia. The trials were all negative with the drug that have been tested up to now, but it's an important area of investigation. I'm not aware of trial coming from the oncological cancer screeners.
Yeah, I agree. Well, the main one is hydroxychloroquine. So you know the drug. We talked a lot about it during the COVID time. So it is a drug that is well known. It has some effect on autophagy, but the very small trial that was conducted not really show any signal. So I doubt it will go further. But the idea is still in the labs. So there are some labs working on that, and probably one day there will be some candidate drug coming out that can be tested. But right now it's still in vitro or I'm not sure it's even in animal models, maybe it is, but so it's far from being tested in humans. And the same for the macrophage. It's still in vitro at the moment. It's ideas. It's very stimulating to see some new ideas coming. There are very different approaches as compared to sirolimus, but they are not ready for be tested in lamb patients.
¿Hay otra pregunta en el chat? Sí, por favor.
Hay otra pregunta de una paciente que os intentaré resumir. Ella pregunta por el cambio de sirolimus a everolimus, porque ella tuvo esta experiencia, tuvo que cambiar a everolimus por un efecto secundario grave con el sirolimus a nivel neurológico, y tiene un poco de preguntas acerca de los perfiles de seguridad de cada uno de estos dos fármacos y también sobre la efectividad en la prevención del neumotórax.
There is a patient in the chat that are asking regarding the change from sirolimus to everolimus and the safety profile of both drugs, and if there is some benefit of everolimus on pneumothorax.
Well, the switch from one drug to another can be done, but like I mentioned, the drugs are very closely related. So sometimes it is said that everolimus is better tolerated. I'm not sure it's really true. I mean, we don't really have the evidence because both drugs have not been compared head-to-head, at least not in lamb, so we cannot say. But individually, if someone is not tolerating sirolimus, what I do is to try to reduce the dose, and if the patient still don't tolerate, then I do try to switch to everolimus, and occasionally patients have tolerated better. For example, I have one patient who had depression with sirolimus and did tolerate better the other drug, but it's very an exception. We have some observational suggestion that the drugs reduce the risk of pneumothorax. I think it's mostly for sirolimus. Fewer patients have received everolimus. I don't think we have that same level of evidence, which is low evidence for everolimus, for preventing pneumothorax.
There is another question. Otra, sí. Un micrófono, por favor.
Or speak up.
O puedes hablar de pie si quieres, sí.
It's coming.
Buenos días. He querido entender que valores altos de la proteína VGF estaban relacionados con el kilotórax. ¿Y un nivel de proteína de unos 400 está relacionado con algún síntoma o no, teniendo LAN, estando diagnosticado, claro?
Sergio, I think it's for you because it's regarding VGD and regarding the level of VGD, VGFD. There is someone that have 400 of level, and we know that when you try to make the diagnosis of LAM, level up of 800 picograms is more suggesting of the diagnosis, and in combination with the CT scan you can establish the diagnosis. And this is related with kilothorax more, or patients that have lymphatic involvement. So where is the explanation, or what are the relationship with other signs or symptoms with low levels of BGFD?
Well, I'm not sure to have understand the question, but we do know that the sensibility of so the number of positive patients with LAM that have VGFD level above the threshold of 800 is around ranging from the series 50 to 70%. So there are quite a number of patients that have normal value of VGFD. When lymphatic involvement is prevalent in the disease, like one case that has been shown by Vincent, for example, or when chylothorax is present, or of abdominal chylus is present, usually the level of the GFD are very high and decrease with introduction of mTOR inhibitors. I'm not sure I have answered to the question.
Maybe you want to explain something?
Well, I will say the same but differently, but I agree with Sergio. So first of all, you can have LAM, definite LAM, and a normal VEGF-D level. That's the case in 30–40% of the cases. And second, in general, a high level is associated with active disease, but active disease more on the lymphatic side. So you can have active disease with lower lung function, but normal VEGF-D. In general, if you have chylous effusions or active lymphatic disease, VEGF-D level is high. So what it means is, yes, it's a biomarker associated with the presence of the disease and the activity of the disease, but it's not perfect.
I don't know the answer completely, but difficult question, difficult. Clear answers, at least, you can have or not have LAM, but with the lymphatic connectivity.
In some individuals, it is not very informative. So if, in your case, the VEGF-D level is in the gray zone, is not very informative, then just forget it.
No sé si hay otra pregunta, si aquí hay más.
Sí, hola. Mi pregunta está relacionada con el embarazo y con el recibir una estimulación ovárica, ya que, bueno, yo soy una mujer con LAM desde hace 2 años, tomando la medicación y todo. Soy una mujer joven y en el momento en el que planteas esto en el médico, pues como que te cierran la puerta, ¿no? Te dicen que, bueno, que es muy difícil y tal, y no sé si hay algún estudio o más información porque no hay un acompañamiento como tal. Y sí que he visto, por ejemplo, en Argentina, en LAM Argentina, que sí que hacen muchos estudios y publican cosas sobre estos temas, pero aquí en Barcelona no.
This is a young patient with LAM that is asking about pregnancy and LAM, because she feels that we don't accompany very well patients on that topic when they are diagnosed of LAM and you ask to the doctor regarding pregnancy. There is always not a good information or a good support for the patients. So she wanted to know regarding pregnancy and LAM, and also a stimulation to be pregnant. I mean, yes, you have present a case like this, yes.
Yeah. Well, probably the patient is right. The problem is that we do not have clear evidence of what we discuss. So we do know that in real life pregnancy can accelerate the disease. We usually, like Professor Cottin mentioned, stop sirolimus during pregnancy, at least during the first 3 months of pregnancy, as we do know that sirolimus is teratogenic. And so it's really an area where there is not a general answer. We have to discuss case by case with a single patient, according also to her history of disease. If the patient is stable spontaneously, is stable because of sirolimus treatment, if we can stop sirolimus and afford pregnancy or not, or if it's risky, we have to discuss all the possibilities and scenario with the patient. Regarding hormonal stimulation, we do not have very strong data. We have only some case report, but I must say that usually I try to avoid hormonal stimulation because we do know that hormonal stimulation can determine a progression of LAM in some patients, and so it's difficult to imagine what will happen after neuromotor stimulation in the single patient.
Yeah, I think it really needs to be individualized as a response, as an answer. Because in general, I totally agree with you, Sergio. But in fact, I've also seen patients with very mild LAM involvement and almost normal lung function, and they couldn't get a pregnancy and really wanted that pregnancy, and ovarian stimulation was apparently the only way to get it. And I think in that situation, we can accept a small risk of the disease getting worse because the benefit of the pregnancy is very important to the patient. On the other hand, if someone has already advanced disease and we are close to discussing lung transplant, you don't want to take any risk. First of all, the pregnancy itself would be risky, and then would be risky because of respiratory failure, and the pregnancy itself or the ovarian stimulation or both could get the disease worse, and you don't want that. So it really depends where the patients are, where the disease is. Is it like mild? Is it advanced? Is it in between? And then you can discuss. If there are no child yet and the lung function is good, I'm rather open, but I explain what the risk is. And clearly, a pregnancy is about halfway risk. So one patient out of 2 or 3 would have some decline in lung function during the pregnancy. Ovarian stimulation, it's not so well known because it depends how many stimulations you get and so on. But clearly you're launching a bomb of hormones, and it's not so good for LAM, but it's usually for a shorter duration.
So thank you very much. There is a lot. Okay.
Del embarazo. Solo necesito que ella tenga la estimulación ovárica para después yo tener el bebé. Claro, el método ropa, que se le dice ahora.
Claro.
En ese sentido nos referíamos nosotros.
I think also the question it was to have an ovaric stimulation to be a donor of ovule to other person, and I think that applies to the same response. I mean, ovaric stimulation, more or less.
But if you don't have the pregnancy after, then the risk is probably lower, right? Yeah. Because it's only, quote, the ovarian stimulation.
Individualize the risk and, of course, the lung function and everything, and make a decision with the physician case by case. So there is a lot of question, but I hope we are not going to wait others until next year to see more advance in LAM, in diagnosis and in treatment. I think every year we make a step forward. I hope that's the hope that we have, especially the patients. But I want to thank you. We need to finish the session and have a break of 20 minutes of coffee. And thank you, Sergio. Thank you, Vincent.